Hi, I'm Doug Dormer. This is the Business of Health Informatics B641. This is Module 7, Lesson 2, my report on the 2025 AMIA Annual Symposium. Let me begin by observing that there are a whole lot of really wonderful conferences you can attend as health IT professionals. For me, however, there are two primary conferences that I try to attend. The first is the Health Information Management and Services Society, or as it's called, HIMSS. And the second is AMIA, the American Medical Informatics Association, the conference that we just had last week. Now, HIMSS is huge. 38,000 or so attendees when I attended the last time in 2024. I missed it in 2025. Whereas AMIA is only about 2,500, 3,000 people. And their objective is different. HIMSS is all about practitioners and how things work fully in the real world. So there's a lot of sales, a lot of technologies that are available. It certainly includes research and benefits, but it's more mature technologies speaking to practitioners about what they need to do their job. AMIA, on the other hand, with its much smaller attendance, is more focused on research, what's coming down the road. And so the economics of the technology is a secondary topic. I find that the combination of the two conferences gives me a very good picture of the industry as a whole. Now, before I go into my immediate reactions from this conference, I have to give you a little bit of background. I started attending HIMSS about 25 years ago. And at the first conference, I was in a session, a panel discussion on consumer health of some sort. And I got in line to ask my questions, as you do, standing before the microphone. And ahead of me was a fellow, a distinguished looking fellow. And as he got his turn to ask his questions, he asked every question I had on my list. So when he stepped away and they looked at me, all I could say, and I didn't put it quite this way, but I was thinking what he said. And so after the session, which ended a few minutes later, I followed him out and I latched onto him in the hall and started walking with him. He said, "Where are you going?" I said, "I'm going where you're going." And we became quite good friends. And that was John Moore. John Moore had started a company called Chilmark Research, which is today the preeminent analytics firm focusing on health information technology. One quick aside about John. Early in that work, when I was early in my career in health IT and he was still early in building his company, Chilmark Research, he would call and say, "What conferences are you going to?" And I would say, "I'm going to the Robert Wood Johnson conference on consumer health, for example." And say, "Okay, I'm going to thus and so other conference. Let's get together after and trade notes." And so early on, these conferences had great value to me, not only for my own education, but I knew I had to report to my friend John as he was giving me value and insight. On one occasion at a Robert Wood Johnson conference, the new technology was about the ability to view lab results and images and pathology reports through your patient portal or your personal health record. And so I asked the question of this distinguished panel, this wonderful doctor that had been giving an excellent presentation, do you filter these such that you need the clinician who ordered these tests to view them before they're made available to the patient? Or do you expect that the patient is capable to receive and should receive these images, this information, before and without the context of the physician's commentary and evaluation? I thought it was a reasonable question. Man, did he humiliate me. He came down on me like it was the dumbest question that anyone could possibly ask. And so I slinked back to my chair and I felt really pretty humiliated. So in my review and my report to John Moore, a few days later, I was telling him that, and I got to about this point in my story, and he said, "That's Bill. You just can't. He's a great man. He's a brilliant man, but he's also an ass." He's going to do that, so just forget that. And then he went into a discussion of the very question I raised, very nuanced, and gave me all the value I needed, indicating that there isn't a firm answer to that, but helping me to think it through in a way that I had never gotten in the absence of his commentary. I can't tell you how often John gave me insights, whether it was through his published work, his public work, or through direct conversations with me. About 3 years ago, I sent him a note, my usual note. Hey, John, can you give me half an hour or an hour to meet with my students to do a virtual, be a guest lecturer for my class? And I didn't get a response. And that was really novel. I mean, we've been doing stuff for 12 years, at least 13 years and more at this point. And so the following few weeks later, when I was getting ready to go to HIMSS, I said, Hey, John, send him a text or an email. I forget, send him an email. Hey, John, when are we having lunch? And I got a note back from him that said, Sorry, Doug, won't be able to attend. I have cancer, and I had hoped to be able to go and make this my swan song, my last chance, a chance to say goodbye to you and so many others. But I'm not able to do that. I'm dying, is what he said. And he died then a few months later, by June 21st. And so I resolved for that conference when he was still alive that I texted like crazy. I reported, I took notes. And so what I give to you today about this conference is a direct result of what John taught me and the tradition I've built of trying to extract information from the conferences in the way that he taught me to do it. So join me in the tribute to John Moore Jr. His son, John Moore III, now runs Chilmark Research. I'm not as close to it, but I believe it's a source you should definitely use to keep your finger on the pulse of what health IT is doing. One of the things John would say is it's not always what's in the lectures or even what's not directly in the lectures. It's the subtleties that go along the way in the process of the conference. So one session that I was very excited to see was titled Funder Perspectives, Shaping the Future of Health and Informatics Research. Certainly I thought that would be great material for our class. When I then got to the room, the sign on the wall said, Getting to Know the Patient-Centered Outcomes Research Institute, PCORI. And my first reaction, did I miss this? Am I in the wrong class? What's going on? So I went in and found that in their opening comments, they said, you'll notice we've changed the course. That's because we couldn't get anyone else from the government to come here and talk to you about funding opportunities. And so that in itself was the first major takeaway for me, that the state of financial support for health IT is so uncertain that only one, PCORI, came and talked about it. Now, PCORI is something that you should look into. PCORI has two parts. One is the financing part that I'll talk about in a moment, the Patient-Centered Outcomes Research Institute. The other is PCORNet, Patient-Centered Outcomes Research Network. PCORNet is significant because it consists of data and information that is used by people who receive PCORI grant funding. And so it's this growing set of data about health IT, about patient experience, about comparative health research. And so you can find an awful lot of information. You can build off of that, but you're expected to contribute to it. So PCORI is a wonderful source for funding. And they pointed out that because, although they're funded by Congress, they are removed from the government so that they were not interrupted, for example, during the recent interruption in federal government funding. Now, the thing about PCORI is that they don't fund initial research. They want to fund comparative research in particular. How does this method work, probably a new method, compared to older established methods for doing something? It also requires that the stakeholders include patients and that patients be represented in the decision-making body around the grant opportunity they're funding. There are some other requirements, but I strongly urge you to look at PCORI. I was thrilled to see that they're available, and the takeaway from this was that it means more important than ever that the business implications of an investment, of analyzing a problem, designing a solution, are more important than ever. whether it's going to PCORI for that funding, for that particular stage, or whether it is something that is to get funding from another source. And of course, now we can no longer rely the way we have from the federal government. The federal government may still be there. The programs may still be there, but we can't rely on them in the same way. I'll give you one quick illustration. There are programs called the Small Business Innovation Research Grant Program, SBIR, and another one that relates to it called the Small Business Technology Transfer Research Grant Program, STTR. So SBIR and STTR. Those have been good sources of funding for what PCORI doesn't fund, that initial research. We have an idea, here's what we think it is, here's the basis, give us some money so we can test it. That grant has not been renewed. So while the government strike may be over, the shutdown may be over, we still do not have funding for new SBIR or STTR programs. Again, it means that we must think of the business value and the economics of what we're doing and make those cases to go after a scarce set of sources of resources for funding against challenging competition. Second observation, AI is maturing. So it's interesting to note how AI has evolved in the period since it was introduced in November of 22 to November of 25. The first time I saw it in a conference, in an AMIA conference, was in March of 23, where a lot of the discussion was about how to use it. And an interesting study was, let's evaluate ChatGPT compared to the medical exams taken by physicians, the qualification exams. We've gone from that to where we are today, where AI, generative AI, has evolved into being almost ubiquitous, even including for our classes. And certainly we see, in addition to generative AI, we see developmental AI showing up in an awful lot of work. But this year, it wasn't the main topic by itself. We need to distinguish between AI models, development models, and generative AI, like ChatGPT and Gemini. But instead of being primarily topics about that subject, this saw topics about using the technology within a larger discussion topic, so a significant maturing. Despite that maturing, we're still seeing it in the midst of the Gartner hype cycle, and we see discussions about being perhaps in an AI bubble from an economic sense and the amount of investment in it, but also from the expectations sense, where expectations may be far beyond what the considerable value that AI can really bring. And so we've talked about the Gartner hype cycle before. I'll refer you back to that. So this technology is maturing, and it's now focused more on the risk and the context and how you use it than on the raw session of the technology itself. To put it in perspective, in March of this year, when I attended the AMIA Spring Conference, there was a half-day pre-conference workshop on AI, how to use AI. That didn't appear to be a focus at all this time. It seems that people are figuring out how to do that, and that part of it's more mature. And now the question is, what does it mean in terms of our broader research, as well as the risks and the context? The one session is a good illustration. This one, Artificial Intelligence and Machine Learning Consortium, was the sponsor of something called Gene Discovery and Drug Development for Alzheimer's Disease. So I think that's a telling statement. It's moved from the latest and greatest and newest to here's what we're doing with it and what it means for us. I think it's an exciting step forward. I went into it looking for health analytics and health data utilities, and it's interesting. Go back a few years, my friend John Moore would talk about health analytics, and he would come up and he would hold open his coat. He'd pull open his coat and say, "Hey, I got some analytics. You want some analytics? I got some analytics right here." He treated it like it was contraband. And that was his way of saying everybody is selling analytics that year. It was the hot topic that year. Today, you don't think of it as a discrete topic at all. It's everything, it's incorporated into everything that we're doing. Also, in about 2022 or so, John started talking very much about health data utilities, the step on top of health information exchange, and how he saw that as the emerging area. I didn't see health data utilities as a topic, as a primary level topic for any sessions this time. I think it's still ahead. I think it's inescapable. I think it's tied to the learning health system, but I don't see it yet. The big questions about the direction that I saw were certainly continuing the health information exchange and not certain where funding will be for that or the political direction. Social determinants of health. What role will they play in the real world in the next 3 to 5 years? The role of the focus on climate and the exposome, which, as we know, is the totality of a person's environmental exposures from conception to death, encompassing both external factors and internal biological responses. So, where health analytics has largely been absorbed into the process and become a core part of what we do, health data utilities, as such, is still kind of evolving. But I think I see where it is when I look at both the learning health system, which again was a discrete topic before, but in 2025, I see a number of presentations that refer to the learning health system and their role within it. So the learning health system has moved from a key session topic to being incorporated into many sessions on other topics. Again, a sign of maturity. As you'll recall from an earlier lecture, back in about 2016, 2017, I predicted that by 2026, we would see a fairly mature learning health system and that would be at the center of much of our work in health information technology, that everything would be a part of a consolidated learning health system. When I look at where we are in 25, I also see that there are many concepts, but with diverse interpretations and implementations. So there's largely a consistent framework, but with a lot of variation in how it gets implemented. And frankly, I won't say competition for who's the ultimate leader, but I see healthy competition for different organizations trying to implement and develop learning health system models. So it's become a critical part of our overall framework, and I think that's a good thing, but we're further away than I originally expected as we move into 2026. Then we have a discussion about diversity, equity, and inclusion. Significantly, AMIA itself is promoting a shift from DEI to something called E2R, which means empowerment, engagement, and representation. And so I think that's a significant piece. I saw that in a number of presentations. Some did expressly refer to DEI, but given the political focus on what are seen as entitlements that are reflected by diversity, equity, and inclusion, it's significant to see that the next step in that, and I view it as an advance, not a simple replacement for DEI, I see the movement towards empowerment, engagement, and representation, meaning that the industry as a whole will continue with the concepts that are reflected by empowerment, engagement, and representation. And I think that is a healthy thing. If you look at the AMIA site, they've got quite a bit of a focus on it right here, where it's including the pillars of their E2R. Build a diverse AMIA, build an inclusive AMIA, build a sustainable AMIA, all around empowerment, engagement, and representation. So when I come to thinking about my big takeaway from this year's AMIA conference, with its focus on the learning health system, with its implied focus on health data utilities, and with the shift from DEI to E2R, I found it came together and it coalesced in work that is being led by the Regenstrief Institute. And I had a chance to speak with Rachel Patsker, the executive director of the Regenstrief Institute, at their event on Monday evening of last week. And she said that during the last year, they have shifted from a primary focus on DEI as one of their two main areas to a focus this year on something called health services research. Here's a good description of what it is. I'm not going to read it to you. I will observe that I think it takes the notions of the learning health system, health data utilities, and the shift to E2R. All of those fold into this notion of health services research. Some of the disciplines, some of the areas that research might include are listed here, from healthcare delivery to finance to quality to patient engagement to the workforce, health information technology itself, as well as social and behavioral determinants of health. An exhaustive list, plenty of room, but from a certain framework that has kind of shows how the other topics from past years have coalesced and morphed into this subject of health services research. Digging a little deeper, how it's conducted. It's certainly a multidisciplinary approach. It focuses on research methods, and it includes collaboration amongst and between different disciplines and parties and technologies. In terms of key players and funding, the comments I made earlier about funding still stand out. Here they mentioned PCORI. As for the others, the AHRQ and the NIH, I think we're not certain what funding they will provide. I think what they don't list here is the funding that needs to be available from private foundations and organizations, usually often aligned with the payers, the foundations associated with the insurance companies. Also, research institutes are where this is often being led, but I don't think exclusively. I think this notion of health services research also includes practitioners, so not just the academic centers. As it says here, professional organizations like Academy Health, and even below that to the organizations themselves. The opportunities are huge. So my key takeaway is that the business case for your problem and innovation that we're working on for our class is more important than ever in this time as we see, for the shorthand, health services research becoming the new framework or point of orientation for what we've looked at and what has evolved over the last several years. That's it for the AMIA update. Next up, we'll talk about a couple of other things, one of which is that nursing is not a profession.